I am Prof Foà, Professor of Hematology and Head of the Hematology Institute in Rome at the University Sapienza. And we're here in Madrid on the occasion of a meeting focused on new treatment paradigms in the management of CLL. And on this occasion, I have the pleasure of being here with Professor Prof Hillmen, who's Professor of Experimental Hematology at the University of Leeds. And we'll have this film interview for ecancertv. So Peter, thank you first of all for accepting to be here with us today. And in the light of what we've been discussing here in Madrid, what would you actually like to say on these new emerging treatment modalities for CLL patients?
I think we have a large number of drugs now that have been developed over the last few years and are becoming available to our patients both in frontline and in relapsed and refractory disease. So we have a variety of classes of drug. We have new antibodies which seem to be more effective than the old rituximab CD20 antibodies. We have this year I think we'll probably get approval of two of the B-cell receptor antagonists, idelalisib and ibrutinib, which promise to change the whole treatment of CLL, certainly in relapsed refractory and probably in frontline. And then in the future with the trials of the BCL2 inhibitor, ABT199, again gives us a different target but equally impressive responses in the early stages of development.
So you would agree that this is we're probably witnessing a major change in the scenario of management of CLL. I mean, would you agree with that? And also the big issue that now we are considering using mechanism-driven drugs, which we did not have for CLL, apart from the antibodies, but now we're considering the validity of these new drugs. So would you consider this a major turning point?
I think it certainly is, and we see in other disease areas that when we get truly targeted treatment that targets the pathophysiology of the disease, you see very impressive responses, which really changes the natural history of the disease and, in fact, our understanding of the disease by inhibiting those key pathways. So it's very clear, I think, in CLL that there are two key pathophysiological pathways. One is the stimulation of the cell through the B-cell receptor pathway, or other pathways, of which ibrutinib and idelalisib are key inhibitors, and then the ubiquitous overexpression of BCL2 in CLL cells, which of course the anti-apoptotic drugs will target.
I think it's also interesting to underline that we don't have in CLL one mutation, so we're not actually targeting one genetic mutation like in CML or APL, but here we're targeting a broader mechanism that is driving CLL proliferation. Would you comment on that?
I think that's true, and I think that leads to several different concepts compared to those other diseases. I mean, for example, the combination of different targeted therapies is going to be an area of very active research over the next 2 or 3 years and beyond, because targeting the leukemic cell, cornering it by using different pathways is going to be I believe, a much more effective way of treating the disease. And then secondly, the emergence of resistance, and I was seeing very early data on resistance for one or two of the compounds, and understanding that resistance, and then understanding how to overcome it, both once it's arisen, what other drugs should we use. There may be some resistance, for example, to ibrutinib, which idelalisib wouldn't work, and some where it would. And should we be combining drugs early to prevent resistance occurring in the first place?
Yes, and I think also for who would listen to our interview, I think it's relevant to underline that we'll probably started to move from a, let's say, more conventional approach to CLL, which has been largely chemo-based with the addition of antibodies, and we're probably moving towards, hopefully at least, a chemo-free approach. Now this opens very interesting also question on a matter of, apart from the mechanism of action, also on the toxicity. I mean, we are much more used, or hematology much more used to toxicity related to chemo, but what about the side effects of these new drugs? And the mechanism of action makes it obvious. We're more controlling the disease rather than debulking. So I think this is something that people would like to hear about.
Well, I think in the initial approval and use of the drug, I mean, there's no doubt that these drugs, ibrutinib and idelalisib particularly, have a profound impact on relapsed refractory disease, on patients who are dying of CLL, if you like, because they failed therapy, 17 pediatric patients, and that's going to change, and has already changed our practice in CLL. I think the first thing to say is that compared to our more intensive chemoimmunotherapy combinations, these drugs are better tolerated. We don't see the same degree of side effects. They're oral agents, occasionally used with antibodies, so that's very positive. We see specific complications emerging which are different for the drugs.
Yeah.
So that may, I think for the majority of patients who don't have significant comorbidities, either drugs can be effective, but there may be certain patients, for example those on warfarin, who you may not want to give ibrutinib to, or those with liver abnormalities you may not want to give idelalisib to, or bowel problems. So we're going to be looking at specific complications and deciding which drugs fit which patients better.
So a very different scenario. It's not so much a neutropenia, infective complication we're used to with chemo. Here we have different scenario of possible side effects. And also another issue is the lymphocytosis, which you can see with these new drugs, which we never saw obviously with chemo. Would you like to comment on that? But something that hematologists may not be so used to.
I mean, it's clear that these drugs inhibit the dependence, if you like, of CLL cells on the microenvironment and vice versa. And we see a pattern of response which is very typical with a redistribution of disease from nodal sites, the marrow, into the peripheral blood, and we expect to see a lymphocytosis. So
not a worsening of the disease.
No, and we see these patients who have lymphocytosis sometimes persistent for months or even beyond a year, who are perfectly well with no symptoms.
Right.
Some of the lymphocytosis can be very dramatic. We've seen patients go up from lymphocyte counts less than 10 up to several hundred within weeks of starting treatment, but the patient's perfectly well. So I think we have to account for that and not consider that a progression event, but it's part of the response to these therapies.
And Peter, on the same line, I mean, we are used to in hematology, like in oncology, talking about complete hematological remission. And with these drugs alone, at least, in the future we'll have the combination study, but we're seeing less remissions. Again, it's not that they're less effective. They were probably controlling disease in different ways. So a comment maybe on that by you.
Well, I think we've done a lot of work over the years, of course, on the depth of remission being important in CLL, MRD eradication with chemoimmunotherapy, predicting for longer remissions, and with transplant. I think that still stands, that if a patient achieves a better remission, they have a better outcome. However, with these drugs, you don't need to achieve that sort of remission to have a prolonged treatment, a relapse-free and good quality of life for patients.
So this would mean that for many patients probably it could be a very prolonged treatment, chronic treatment over time, like we use in other hematological malignancies.
I think that's going to be a challenge for us, and we as the drugs are approved, as I said, probably this year in Europe, and we start using them more widely, they clearly have a role. Both ibrutinib and idelalisib with rituximab have shown a survival advantage even in a short follow-up in their trials in refractory disease. So that changes the outcome for those patients. I mean, I think the real challenge for us is how do we bring these drugs earlier in the disease course, prevent the complications of chemotherapy. There's a large number of CLL patients. How do we combine them together to hopefully not have patients dependent on drug over a prolonged period of time? So I think at the moment we have it's really important that the patients are benefiting from therapy, but the way we use them, the way we develop the drugs together and with antibodies and with chemotherapy is going to be key.
You mentioned earlier a possible issue of resistance over time, because again we are talking about drugs which have a completely different mechanism of action. So talking about resistance, what could actually occur with these new classes of drugs?
So we have some data, and it's obviously emerging. The first thing we have to remember is we have data only really going out to maybe 2 or 3 years for a large number of patients, 1 or 2 trials longer than that, and so we're seeing the emergence of a small proportion of patients to resistance to both agents. We have some molecular analysis with the ibrutinib patients. So what we see is that these drugs because they target a molecule or a pathway, if the tumour can either mutate the target or downstream of the target, then you get a selective advantage for that mutated clone. So unlike chemoimmunotherapy, where you get p53 emergence and a general sort of progression of the disease in that way, this is a more treatment-specific avoidance of that therapy. And so it may well be that you will look at the type of resistance and then use another therapy, whether it be ibrutinib, or 199, or chemotherapy, and we have no data on chemotherapy after these agents, to try and overcome that resistance.
And I think we should add that so far resistance we've seen in patients who've undergone multiple lines of treatment before, so we'll have to see what happens when you start using drugs up front, obviously.
And it's a small proportion of patients.
Absolutely.
And we don't know what's going to happen, for example, in frontline, where the drugs seem to be better tolerated, the early responses look even more promising, and it may well be that because they haven't got, as you said, sort of multiply pre-treated and very selected patients, we don't see that level of resistance.
So thank you very much, Peter. I think if we could conclude, and I hope you'd agree with this, I think we are witnessing a major change. I mean, going from chemoimmunotherapy, we are really starting to consider a different approach based on a mechanism, on a biological defect in CLL, which is not one defect, it's on pathways, and the drugs seem to be extremely efficient. That's underlying that it's an oral form of treatment, so this makes a big difference. Toxicity is much more limited in a way compared to conventional chemotherapy, different, but much more manageable. And this is very important for a disease like CLL, where most of the patients are over 70 when they need treatment, large majority. So I think this makes it a very challenging time for us. I think it's a very exciting time for the management of CLL. And I think if you agree with that.
I think there are challenges, of course. So we have, for a relatively small proportion of patients, the fit young patients, therapies that put people into remission for 6 years, or many people off treatment for over 10 years and see the doctor every 6 months, have no dependence on therapy. And for that group of patients, should we be using these agents frontline? We don't know. For the elderly patients, the ones you mentioned, we don't have effective therapies in reality. Chemoimmunotherapy with chlorambucil gives remissions of 18, 24 months, maybe a bit longer, but really not adequate. And we're going to be moving these drugs into the so-called sort of slow go, or even patients who would not be considered for chemotherapy because
they
they're
might
so well
be eligible
tolerated.
for these new drugs. Absolutely. So I think we'll stop here, and thank Professor Hillmen once again for this chat we had today, and from Madrid, where we were talking about these new developments in the management of CLL at a very exciting time. So Pete, thank you very much for being with us today.